Vaccination is a vital public health tool that protects individuals and communities from preventable diseases. It's crucial to understand the science behind vaccines, the importance of vaccination. Tonight, On Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. I'm Dr. Kelly Evans-Hullinger, your volunteer Prairie Doc for this evening's program. Tonight we are discussing vaccines and answering your questions throughout the show. Vaccines are biological preparations that provide immunity to specific infectious diseases by stimulating the body's immune response. Vaccination has been instrumental in reducing or eradicating diseases like smallpox and polio, significantly lowering disease incidence and mortality rates. Despite some public concerns and misinformation, vaccines undergo rigorous testing for safety and efficacy before being approved for use. Widespread vaccination is crucial not only for individual protection, but also for achieving community immunity, which helps safeguard vulnerable populations who cannot be vaccinated. In the studio this evening are Dr. Ashley Sands from Sanford Children's Specialty Clinic and Dr. David Basel from Avera Medical Group, Harrisburg. Thank you both for being with us tonight. Dr. Sands, tell us a little bit about your specialty and what you do and why we invited you to the vaccine show.
Sure. Thank you so much for having us. So as a pediatric infectious diseases physician, I see children who, for one reason or another, come into some sort of infection usually. So I see children who have prolonged fevers, who have pneumonia, might need a chest tube for a complicated pneumonia. I see meningitis. I see lots of different patients for various reasons. And a lot of the things that I see sometimes can be prevented with vaccines. I also see some patients for immune deficiency, so seeing some kids who might not have as robust of an immune system who need help from their friends to be vaccinated to help keep those illnesses at bay.
Yeah. Great. Well, thanks for coming. And Dr. Basel, you have a leadership role in the Avera health system that covers a lot of our area. Tell us a little bit about that and how you've kind of become more involved in vaccine policy with that role.
Certainly. So I'm the population health officer for Avera. So my role at Avera, I work with a lot of different quality items, everything from reducing falls in the hospital to improving cancer screening to also working to improve immunization rates. And so that's kind of any of those key quality metrics tend to be the things that I get involved with and help with.
Yeah, great. Well, thank you both for being here. Let's start with some very basic stuff. But before we jump into our discussion, I'd like to take a moment to express my thanks to all our viewers. Every dollar you give helps us produce science-based content that empowers individuals to make informed health decisions. So, the basics. Dr. Sands, what is a vaccine? Like, how do we define this entity that we call a vaccine?
Yeah, it's a great question. A vaccine is really a tool that our immune system uses to help recognize pathogens or the bad guys, the viruses or the bacteria that can really cause some pretty damaging, life-threatening diseases. So by using immunization or a vaccine, you're giving your body generally a little bit of that pathogen to recognize, so that in the future, if you are to come into contact with that pathogen again, your body will be able to respond quicker, have a shorter illness, have fewer symptoms, or even not have that illness at all.
Right. Yeah. I don't know about you guys. Maybe we're all a little nerdy, right, in medicine. Some of my favorite medical history has to do with vaccines and like the discovery of the immune system. So, Dr. Basel, like, how did we start making vaccines, or like where did this even come from? And because it's evolved a lot since its start, right?
So I love some of that history of things as well. And the story that always sticks with me is with the smallpox. And I forget, you probably could tell me whether it was Pasteur or who, that realized that individuals that grew up on dairy farms and were milking cattle or sheep did not get smallpox. Right. And they realized that they were getting infected with a cousin of smallpox, which was like cowpox, sheeppox, something like that, and that inferred immunity to smallpox. And so they actually started taking, when the livestock would have cowpox or smallpox, they'd actually take some of that fluid and prick out on the skin of other people and realize that prevented smallpox as well. And so those were some of the very first vaccines, was, and just somebody who was really observant and figured that out, and things took off from there.
Right. And smallpox, used to kill.
Oh yeah.
Huge
it was
swaths
devastating.
Of population and young people, babies, children, and now it doesn't exist. It's like the most amazing story maybe in medicine. I think
it really is.
Yeah. So vaccines are awesome, is what I'm getting at, right? But there are a lot of different types. So not all vaccines are the same, right? So what are some examples of how we use, like you said, parts of the pathogen that we introduce? What are some of those parts, or how do we do that?
Yeah, so there are, in general, we think of vaccines as either live or inactive or killed, and then the subclass of mRNA vaccines. So a live vaccine, like the measles vaccine, takes a little bit of that virus injected in, and then your body kind of has to fight that virus off. Similarly, the killed vaccines, it's not as, your body still has to make the antibodies to it, but it's just not a piece of the pathogen that will actually make you sick. Right. And then mRNA, it's a different technology, newer, but really has been studied for 15, 20 years now, where we're taking that DNA, so the body's immune system can then recognize that DNA and create antibodies to that pathogen.
Yeah. So different ways to do this, and that's changed over time too. And do you have anything to add? There's some vaccines that really just use a small piece of what would be visible and isn't actually any bacterial or viral material at all, right?
The way I describe it to patients, to try to put it in kind of straightforward, is I talk about the cycle of an infection being a race. And so let's say somebody next to you has a common cold, rhinovirus, and coughs, and you get a little bit of rhinovirus in your nose. And so the clock starts ticking because that rhinovirus attacks those cells in your nose and then takes over those cells to start reproducing or replicating additional copies of itself, which then it spreads, and you get more and more, which then affects other cells. And so it's this race then, because eventually your body recognizes that rhinovirus as foreign, mounts immune response, starts producing antibodies and infection-fighting cells, which then get on top of that, clear that infection. But it all comes down to how quickly can that immune system ramp up, recognize that as foreign, and then mobilize to fight that and get down. Vaccines give you a head start in that because they give you, some of those exterior parts of that virus or bacteria so that you recognize it quicker. You've got kind of a bench of antibody producing cells and infection fighting cells that recognize that as foreign quicker, can mount that response quicker, and get on top of it. So like you said, you may not even know that you were ever even exposed to it because you can get on top of it even before it even becomes symptomatic. But even if you don't get on it quick enough that you do get some symptoms, they tend to be shorter, less severe, less likely to put you in a hospital, and it also reduces the number of people you're going to spread it to.
Right. Which is a good point, right? Vaccines don't necessarily prevent any illness from occurring, but they do all these other things if you do get the illness. Great. So we're kind of in the end of October here. I'm getting a lot of questions about some of our seasonal vaccines. So I guess let's talk about a couple of those things. Certainly the most common would be the flu vaccine that we're talking about. So tell us a little bit about influenza, what we can expect a given influenza season, and remind us why we should get the flu shot.
Yeah.
Let's start with that.
So influenza, another common illness this time of year throughout the winter. Usually you have a high fever, you might have those runny nose, cough, body aches, chills. You're probably going to feel not good. Probably staying home from work for 5-7 days, maybe even longer. And then some of the complications can be a bacterial pneumonia. You might end up in the hospital because you're not able to drink enough to keep yourself hydrated. You might have a really bad pneumonia, need antibiotics, might need some help breathing. So we have the influenza vaccine, and we have that in both a live vaccine that you can get through a nasal breathe in. It's not an injection, but you just breathe the virus in, and it goes to your lungs and helps fight if you ever do come into contact with influenza. And then we have the inactivated one that usually is the injection in the arm. And that really shortens the duration of your symptoms, will make them more mild, and will prevent those complications, keep you out of the hospital.
Yeah, good. Why is it among, a lot of vaccines we get once or maybe twice? Why do we have to get a flu shot every year? I get this question a lot.
Yeah, so if you take a virus like tetanus, say, tetanus changes very little. The tetanus that we get exposed to today is the same tetanus we got exposed to 25 years ago.
Right.
And it also is relatively slow growing, so that, if I had a tetanus vaccine 7 years ago, it still gives me enough of a head start that I'm going to be able to get on top of tetanus. Influenza, one, is quicker growing than tetanus, and so you've got to have more of a head start, but also two, influenza is classic for mutating and looking a little bit different every year, and there's multiple strains that you're having to keep up with. And so the influenza we saw last year may be quite a bit different than what we see this year. There's things called shift and drift, and so you've got to stay up to date so that you've got as close of a vaccine to what's likely to be circulating that year.
Right. So unique to the virus itself is part of the reason. And then how about kids getting the flu vaccine? What do we recommend, especially like in infants and that group?
So we recommend the influenza vaccine for all children starting at 6 months of age. 6 months is the youngest you can get it.
Okay.
In their first season, a child needs 2 vaccines, usually given 1 month apart, and that's just to help build up their immunity. And then again, every year. Last year was a horrible year for influenza in both adults and children. There were 280 pediatric deaths related to influenza in the United States.
Yeah. I think we don't hear about that.
Right.
Like, that's real.
Doesn't seem like a lot in the scheme of things, but that's 280 possibly vaccine preventable deaths. So children are still dying, children are hospitalized. If your child is sick, you have to take off time from work. They can't go to daycare. So it really has kind of the snowball effect if your child is sick. And yeah, so.
Yeah.
Adults, it's similar. It's still one of the leading causes of death in the winter months among, especially like nursing home residents.
Sure.
But, even hospitalizations, not in nursing home age, in the 60-plus population, it's still one of the highest things we see in the hospital during those winter months. We, after going through COVID, we think, influenza is not that dangerous, but it really is. And the numbers, when you actually look at the numbers, they're still pretty staggering. Especially, I agree, last year was a horrible year.
Yeah. Let's talk about COVID-19, because I feel like so many of my patients have kind of gotten their influenza COVID-19 injections around the same time annually. What are we recommending at this point for COVID-19 vaccines year to year?
Yeah, so COVID, kind of like we talked with influenza, COVID does mutate every year, and so you do have to keep up with what is the latest strain that you're seeing of the COVID every year. And so the recommendation is, again, this year, everybody 6 months of age and older to get your annual COVID vaccine, just like you do your influenza. They can be given at the same time. I just got mine a couple weeks ago. I got COVID in this arm and flu in this arm on the same day. And so it's that time of year we're getting into that season.
Good time to just
influenza usually has a very typical peak in December and then a second peak in January, February. COVID is still kind of more year-round, but we do anticipate that we'll see a winter peak as everybody comes in and gets exposed. The air doesn't get turned over as much, and so we are anticipating, the numbers will increase again this winter.
Yeah. How'd you feel after your 2 vaccine day?
A little sore right around it, but
otherwise good.
Yeah, fine.
Yeah, great. COVID vaccine in children. Tell us what is the American Academy of Pediatrics recommending at this point?
So the American Academy of Pediatrics, or AAP, is recommending that all children between 6 months and 2 years of age get their initial vaccine series, and then their second one, or however many in their up until 2 years of age, because we know that those children are at the highest risk of being hospitalized from a COVID infection. They are also recommending that every child who is high risk, so if they're immunocompromised or at risk of severe disease, whether that be from obesity or other underlying conditions, that they also get vaccinated every year. But really recommending that if any parent comes in or any teenager comes in and wants to get their COVID shot, that they should get it.
It's safe.
It's safe. Yeah. It's effective at keeping people out of the hospital. Yeah.
Okay. Let's talk about one more vaccine before we go to our first roll-in that I'm also getting questions on, and that's RSV.
Yeah.
This is a new kid on the block, kind of, and so I see the folks who are 65 and over, 60 and over, and qualify. You're seeing this in a different setting because we're talking to pregnant women and children about a different kind of product. So I guess, what's RSV? It's probably more relevant in the pediatric world, and tell us about these new products that we have to offer.
Yeah. So RSV is respiratory syncytial virus. It is another cause of the common cold, probably older children and adults. But in infants, it just creates a lot of mucus, and their airways are so tiny that it clogs their little noses, it clogs their lungs. They can it leads to them having difficulty breathing. Sometimes babies even stop breathing altogether because of all of this mucus. And RSV is the #1 cause of hospitalization in infants up to 3 months of age.
Yeah.
So in 2023, we have this new vaccine. It's actually not a vaccine in the traditional sense. It is a monoclonal antibody. So we're giving that baby the antibodies that if they come into contact with RSV, they have that head start. And what we've seen is that even in that first year, 98% effectiveness at preventing a baby from being hospitalized, and 87% effective at even preventing any sort of respiratory illness.
Yeah.
So this is a huge win.
You have to be ecstatic about this, right?
Like it's
totally
one of the best things I've ever
it's
seen.
Remarkable.
Yes.
Yeah.
The peds units in the winter, prior to 5 years ago, whenever it came out, were just packed, in January, February, they were just packed full of 1 and 2 year olds with bronchiolitis from RSV. And now that we've got the vaccine, it's relatively rare that we see somebody in the hospital. There's still a few breakthroughs or a few unimmunized here and there, but it is night and day different from what when I trained and stuff when we didn't have the vaccine. It is remarkably effective.
Amazing. So you're mentioning the option that we give to the newborn child if they're kind of in the right season. Am I right in thinking that another option is for during pregnancy to get the traditional RSV vaccine that then those antibodies get passed to the growing fetus? Is that accurate?
That's correct.
Yeah.
So there's the infant product, which can be given from birth up until 8 months of age for the infant entering the RSV season. And RSV season is typically November to late March, early April.
Right.
So we start giving those vaccines October 1st, go through the end of March. We can give pregnant moms, the RSV vaccine, generally between 32 and 36 weeks gestation. And that starts September 1st and goes through the end of January. And in that case, if it's given sooner or far enough before the baby is born, that baby should be born with antibodies and also have hopefully be protected against RSV.
Yeah, so cool. Yeah.
And so you've got the very young with the RSV, but then we've got the other end of the spectrum as well. And so, like you said, in kind of our age group, RSV is likely to cause a common cold. But as you get into more the geriatric age group, it starts to become more of a problem again. And so nursing home individuals or the elderly, especially with chronic medical conditions, heart and lung disease and stuff, we start to see RSV cause hospitalizations and even death again. And so there's an adult RSV vaccine for those at higher risk and older individuals as well.
Right. And unlike the flu vaccine, as of now, this is a one-time recommendation. So it's not something we're going to be telling you to get again next year. Yeah.
The only other point is that infants who are at high risk, so here in South Dakota, that includes our Native American population, and then any babies who have chronic lung disease or lung conditions who are premature and maybe need a little bit of oxygen, they can get it in their second fall season as well.
Okay.
Yeah.
Excellent. Well, the pediatric vaccine sequence, which is the recommended immunization schedule for children, prevents serious diseases. Prairie Doc spoke with Dr. Alexandra Gower, a family medicine provider at Prairie Lakes Healthcare System in Watertown, about this sequence and its importance.
It was set by the CDC sort of indirectly through the ACIP, which is the Advisory Committee on Immunization Practices. They go through all the data, look at, which vaccines do people need when to provide them with that immunity from that disease.
The schedule begins at birth by protecting newborns from potentially serious illnesses they may be exposed to early in life.
Like I had said earlier, they're chosen based on how a child's immune system is going to respond. So children are born as babies with fairly naive immune systems. Obviously, they haven't been exposed to a ton in utero, so their body is ready to process all of these immune stimulating products. So they're being exposed to everything just by being in the air and being around people because they are kind of fresh, for lack of a better word.
She says vaccines are well developed, so multiple immunizations are safely combined into a single shot.
Overall, they're all very effective at preventing their illness. That's why they've been around for so long. That's why we keep using them. They work very well. That's why we, don't have polio anymore and those sorts of things. So that's the nice thing is you can rest assured that these work. They very rarely, very, very rarely don't work. And because they work so well, we now have really good herd immunity, which also helps add added protection to the community, in that enough people are immune that people who, couldn't get vaccines because of some autoimmune disorder or are too young to get them yet, it offers them some protection too, because it's not just floating about in the community.
Great information. We've seen so much in the news about things like vaccine recommendations and things like that. So I guess just stepping back, how did this schedule get developed? Can we have faith in the process that this schedule came by? What would you say about any concerns about that?
Yeah, Ashley? So it seems scary when you're a new parent and you're going and you're taking your child, and it seems like you're getting a lot of vaccines for your child. But when we think about everything that an infant is exposed to in the world, the vaccine part of it is such a small piece of it. Just the number of antigens, and when I say antigens, it's bacteria and viruses, little pieces that the body is exposed to. So the number of antigens in the vaccines have come down so much since we started developing vaccines, that it's just minuscule compared to, like I said, what they get exposed to on a day-to-day basis. And as we have developed vaccines and learned more about these illnesses and when people get exposed to them, we want to give them to infants and people well before they'd ever come in contact with that virus or that bacteria, so that when they are exposed, they have the best chance at fighting it off. So that's why we really recommend doing these vaccines starting at 6 weeks or 2 months of age and continuing throughout childhood and getting them on the schedule. The AAP has an excellent schedule that's put out a couple months ago. And really following those guidelines so your child has the best fighting chance with things they're exposed to.
Yeah, great. In the setting that maybe we missed an appointment, maybe we weren't sure and we wanted to get a little more comfortable. What if we're late? I mean, what do you tell parents? Or, I mean, occasionally I'll have a new adult in my clinic that maybe didn't get their childhood vaccines. Can we give them late? Yeah.
Yes.
Right?
It's never too late to play catch up. There's a whole catch up protocol of, you know, how quickly can you give vaccines, because you've got to give the body time to respond to the first one and then give the second one. And so that's been extensively studied of, you know, what's the right cadence of developing an immune reaction to those. And so just because you missed one, that doesn't mean that you're not going to be able to get it, you know, except in a very rare, you know, maybe rotavirus in kids or something like that you outgrow. You know, it's never too late to start or to finish.
Yeah, great. Well, let's talk about one particular pediatric vaccine, just because the disease has been on our minds lately, and that'd be measles, part of the MMR, measles, mumps, rubella vaccine series. So, I mean, what is measles? How long has the MMR vaccine been around? Let's talk about that first.
Yeah, so measles is a virus that causes people to be very ill with high fevers, usually high fevers for several days. And then after 4 or 5 days, you break out in this characteristic rash that starts at the head and kind of works its way down the body. You also have cough, you could have runny nose, conjunctivitis or red eyes as all part of this, this illness. And the problem with measles is that it is the most highly contagious virus that we know about.
More than flu, more than COVID, not even close, right?
Not even
like
close.
Spreads like wildfire.
If you've got 10 people in a room and one of them has measles, 9 out of the other 10 will get it. You know, it's just, if you're unimmunized, it's just remarkable how fast it'll spread.
Yeah.
And it stays in the air and on surfaces for up to 2 hours. So, you know, you could walk through this room, somebody could walk through with measles, cough, and then we come in an hour later and still become infected from it.
Yeah.
So, and it made people very ill, hospitalized. You'd have, again, pneumonia, ear infections. A lot of people died from it. So it was highly important to get a vaccine available for it. Our vaccines have been available since the 1950s, 1960s, and it's been recommended in this MMR vaccine since 2 doses since the 1990s.
Yeah, great. So tell us a little bit about vaccine rates. You know, measles was gone for a while, and now we're hearing about it again. And what's happened?
I've always thought we're a victim of our own success. Like some of those family stories, people have forgotten what it was like before we had these vaccines. You know, we still talk about my family. We actually lost a great aunt to measles, to tetanus. You know, before there was vaccines for it. I'm old enough to have been practicing that I've seen, you know, meningitis from these vaccine preventable illnesses that have caused just devastating, you know, kids losing, you know, fingers and toes and things to meningitis, you know, that today would be vaccine preventable. And I've never seen measles because we thought that was totally eradicated, just like smallpox. We thought we'd won the battle, but then over time, you know, we saw a gradual decrease in immunization rates to the point where, you know, some little pocket of it somewhere had flared up, and all of a sudden it's so contagious that it's starting to spread worldwide. And it's something that we talk about. Never something I thought I'd talk about in my medical career, but here we are.
Right. And you mentioned how contagious it is. So just so maybe a parent might have an idea, what would happen if measles was in my kid's school? What are the recommendations if you are a child that hasn't been vaccinated and you have an exposure? It's like a long quarantine, right?
It is.
Yeah.
The quarantine is 21 days.
Yeah.
So 21 days from exposure. So if your child is in school and with somebody with measles today, they're out of school for 3 weeks if they haven't had a vaccine.
Right.
If they are up to date for their age, based on their vaccine, they can still go to school. You can still go to work.
Right.
Yeah, so that's a good point. So we talked about the fact that the bad news about measles is that it's pretty much the highest contagious virus out there. The good news, it's also the most effective vaccine that we have out there. It's a remarkably effective vaccine.
Yes. Yeah. And how about, I'm getting a lot of questions from my adult patients. You know, I was born in the 1950s. Do I really still have immunity? Or I had a vaccine, you know, in the 70s. Do I really still have immunity? What's the advice to adults that are worried about measles if it's near our community?
Yeah, so we talked about earlier that some viruses like, say, tetanus really don't change over time. Others like influenza or COVID do change, and you need those boosters all the time.
Right.
Measles that we see today is the same measles that they would have seen back in the 50s and stuff.
Right.
And so if they're really sure that they got a measles vaccine back then you really don't need that follow-up booster at this point.
Yeah, good. We still assume protection. And if you're born before, is it 1957 or something, then we assume that you had measles.
Right.
And same thing as far as immunity, right?
Yes.
The measles brings up that concept of herd immunity or community immunity. What does that mean, and why is it relevant in diseases like measles?
Yeah, so it's a great question. Community immunity really just talks about how many people in the community are vaccinated. And as more people in the community are vaccinated against one particular disease or pathogen, the likelihood of it spreading from person to person really decreases. And why we talk about that is because we have those members of our population who are more vulnerable. So infants who are too young to be vaccinated against measles, children, in my instance, who are being treated for cancer, who cannot get vaccinated and would become devastatingly sick from one of these illnesses. So we like to keep it higher the vaccine rates higher in the community so that we can prevent that vulnerable population. And with measles, because of how contagious it is, we really need to see like 90 to 95% of the population with full immunization against measles.
Right. So that's a number that varies by disease because of those factors of contagiousness, but that's important. You mentioned kind of just maybe complacency and the absence of measles as maybe one reason that we've seen vaccine rates go down. But this was also maybe the vaccine that started this whole business about some of the misinformation that we're still fighting, right? What do we know, just to put it to rest, about MMR vaccine and the concern about autism in children?
So this goes back, I don't know, I think it's 25 years because I remember it was
the 90s, the late 90s.
It was a small study, and they were studying over in, I believe, England, and they were looking at something GI related with colonoscopies or something. I forget what the initial, it had nothing to do with looking at vaccines, and it was a small study, like 50 people, but they just gathered a lot of data, and they just randomly noticed that the people that got MMR vaccine more of those had autism than the other. And so, but the numbers were very small. And so it's like if you were to take a quarter and flip it 10 times, and you did that 10 different times, one of those 10 times, probably 7 of those would be heads. And so you're like, oh, is that random or is that something? And so when you've got small numbers in a small study, they're like, we better study this in a big one. And so since that initial tiny little study, they've done huge, tens of thousands of people studies. And clearly there's no difference in autism between those who get it and those who don't. But it's still, the other side of that is you get your MMR vaccine at about 1 year of age. And the classic age when you start noticing autism symptoms just from natural peds development is a little bit after that 1 year of age. And so that time is in that same time frame, and so people sometimes make that connection, but it has been so extensively studied and just nothing there.
And I think you're being kind even about this study. I mean, I think there was actually a little more poor intent found, and the person that was the lead author lost his legs. I mean, it was a big deal, right?
It was only 12 patients in the study.
Wow.
And what came out is that he had a competing vaccine and manufactured the data. So not only was the study retracted from the Lancet, he lost his medical license and is not allowed to practice medicine anymore. So,
but so much harm was done.
So much harm.
And it kind of snowballed into some other various misconceptions that we can talk about a little more if we have time. But yeah, great. We're going to change gears a little bit. Shingles is a painful rash caused by the reactivation of the chickenpox virus. And getting vaccinated helps prevent severe nerve pain, long-term complications, and the risk of the disease altogether. Ross Tellinghusen, chief pharmacist at Lewis Drug and Brookings, spoke with Prairie Doc about the importance of the shingles vaccine.
And chickenpox are caused actually by the same virus, the varicella virus, and so shingles is basically the chickenpox virus that we all get as kids or have a vaccine for as kids, lays dormant after you have the chickenpox virus, and eventually it can kind of come back to life, and that's what causes the shingles rash.
Tellinghusen says the shingles vaccine is recommended for anyone over the age of 50. Adults that are immunocompromised can receive it as soon as age 19.
It's recommended basically to prevent shingles. Shingles can cause other type of debilitating issues. Pain, depending where it's at, can cause vision loss and all kinds of other things, but it basically prevents the shingles virus from coming back and hopefully preventing the disease.
The shingles vaccine is given in 2 doses.
For normal adults, it's 1 vaccine, and then the second vaccine takes place 2 to 6 months after the first vaccine. The shingles vaccine is actually one of the most effective vaccines that we offer. Depending on the age that you get the vaccine, adults 50 to 70, they say it's up to 95% effective. As you age and your immune response kind of declines a little bit, it goes down to about 90, but still 90% is a really good number when it comes to vaccines.
He says that the shingles vaccine is recommended for individuals regardless if they previously have had chickenpox or shingles.
The shingles vaccine, as of 2023, is covered completely for those adults on Medicare. Also, we've seen private insurances cover the vaccine very well. And also, there is still a lot of vaccine incentive programs for people that don't have health insurance that can help with the cost of the vaccine itself.
Great information. Thanks to Ross there. This vaccine that we're talking about is a relatively new vaccine to the newer shingles vaccine, but it's related to a vaccine that we now offer in childhood too, right? The varicella or chickenpox vaccine. So I'm even, sometimes I feel old. I don't think I'm as old as I am, but I got chickenpox when I was a kid. How long has the chickenpox vaccine been part of the childhood vaccine schedule?
The chickenpox vaccine has been around since the 90s and recommended since then. Yeah. And yes, there were chickenpox parties. I have the photo of myself in my Care Bears robe with calamine lotion all over my face. But while people think again that it was just fine, you got some spots, you stayed home from school, there were lots of complications. Children would get pneumonia. It's a common theme. Viral illness leads to a bacterial pneumonia, but also get strep infections, and so they would get really sick afterwards. So it became important to start preventing that. Yeah.
So chickenpox pretty uncommon in kids anymore?
It is still something that I don't know that I've seen in the last 5-10 years. Yeah. Similar to MMR, we give them at the same time, usually at the first birthday, and then again, right as you're getting ready to go to school, so 4 or 5 years of age. And there is a combined vaccine that we tend to give to the 4 to 5 year old age group. We still tend to give the 1 year vaccine separate because there is an increased risk of febrile seizures if you give the combined vaccine as your first vaccine product. So we don't like to take that risk sometimes.
Yeah, great.
Early in my training, I saw multiple cases of chickenpox in the hospital and stuff, but by the time I'd finished my residency, the vaccine was pretty widespread, and anybody that trained after me, it's really almost never seen it. It's hard to recognize for them.
For all our many patients born before the mid-90s, we assume everyone had chickenpox, whether mild or whether they remember it or not, right? And so shingles is a reactivation late in life from that virus. Who should get a shingles vaccine and why? Why do we care about this?
If you've ever known somebody that got shingles, you'll understand why to get the shingles vaccine, because it is what it hides in the spinal column your entire life, and then as you get older and your immune system starts to back off a little bit, it pops out along one nerve root, and it irritates and can cause permanent scarring for that nerve that causes pain in that nerve for, it can be years.
Right.
And so, to get that shingles vaccine as you get to those older ages, so that you ramp back up the immune system so that it doesn't escape back out there, and it can be one of the most frustrating things, because it's not like you're going to be sick for a couple weeks. It can damage that nerve permanently.
Long-standing for some people, and so everyone over 50 is eligible for this. And actually, I have some people who had the old shingles vaccine, the old Zostavax.
Yep.
This one's way more effective, right? So even if you had the Zostavax, we recommend getting the new one. Okay. We've talked a little bit about, like you mentioned, febrile seizures, adverse effects from vaccines, and certainly they happen. What are the common adverse effects from vaccines? What can we expect? What should not rattle you after you get a vaccine?
The most common one is really injection site pain. I also last week got COVID in one arm and flu in the other, and I had a sore arm for a few days in my COVID arm. And then other things are, you might get a little mild illness, and that's your body reacting to the particle and fighting the fight. But really, that should all be better in a couple days at most.
Right.
But really, injection site pain is the most common.
Great.
That's actually probably one of the biggest myths around vaccines, is vaccines do not cause illness. Back to kind of our earlier discussion of how vaccines work, is they're a inactivated version of the virus, or they're just a small little protein off of the virus, something that triggers the body to recognize as foreign and mounts a small immune response. And so it is an actual immune response you're hoping to get. So all of those nonspecific inflammatory things of feeling a little achy, maybe even having a low-grade fever, a little bit of soreness at that spot, that's a sign that the vaccine's actually doing what it's designed to do. The flu shot absolutely cannot give you the flu, but it can, it causes an immune reaction, which is what it's designed to do, so that you don't get sicker later.
Right. And, sometimes I'll see someone who says, well, 5 years ago I got my flu shot and then I got sick, that next week. Probably those are coincidences, because you can't get that actual illness, but there's still colds around, right?
Yes.
You mentioned there are some kids like that you see who cannot get vaccines, and of course age might be part of that, and we can look at the vaccine schedule, but who else can't get some vaccines? Like why can't some people get vaccines?
Right, so children who have immune deficiencies, HIV, inherited immune deficiencies, or kids who are receiving treatment for cancer, maybe some other things that are treated with immune modifiers for Crohn's disease or some autoimmune things. Certain vaccines they are not recommended to get, so are live vaccines like MMR. And that's really it. That's really the only medical contraindication to not getting a vaccine, is really if you don't have the immune system that could support it, or would get very, very sick, or not make a response.
And only for a small portion of the vaccines that we offer. There are a lot of vaccines that those patients absolutely should get, right?
Yes.
How do you approach, I have some patients who maybe they're on chemotherapy for cancer, or maybe they are on an immune suppressing drug for some chronic disease. How do you approach, is there a better way to time vaccines sometimes around those things? Sometimes I have to ask my consultant, the oncologist or the rheumatologist, how we should go about this, right?
Some of these get pretty complex. So some of these medications that suppress the immune system, and you want to give that vaccine at a certain part of the cycle where the immune system is most likely to be able to mount the response before you kick the immune system back down, whether they're undergoing cancer treatment or whether they're on some sort of autoimmune disease that has a immune suppressive drug in it. And so that can get to be a pretty complex timing question sometimes. And so when in doubt, go see your physician. They can consult an expert, on that certain medicine or immunosuppressive disease that you have, and we can work with that on when is the right time to time.
Good, and another good message might be the best time to get a vaccine is when you're healthy, right?
Yeah.
Like before you're dealing with some of this stuff.
That's another great point about vaccines that I think sometimes we forget about and the general public doesn't think about. Vaccines, we give the shot and we mount immune response. It takes 2-3 weeks at least for that to really get ramped up and become an effective response. And so you don't want to wait until, I'll wait to get my flu shot until I hear Dr. Basel on TV talking about that we're seeing a bunch of flu cases. It may be too late at that point because you've got that 2, 3, 4 week window before it really becomes effective. So you want to get your flu shot now in October and November so that when we start seeing flu in December, that it's had a chance to become effective.
Right. And just to be clear, when we're talking about all these other vaccines that are not the live ones, it's not dangerous for someone getting chemotherapy to get that vaccine. It's just not going to be as effective, right? Because your immune system's not healthy enough to mount a response. So trying to time that to maximize efficacy is what we're talking about here, right? Good. A couple of categories that we haven't really hit about vaccine. One that we get a lot of questions on kind of in both worlds would be the HPV or human papillomavirus vaccine. So who do we recommend this for and why?
Yeah, so we start vaccinating children at the age of 9 to 11 years old. And we do that, again, way before, hopefully, they are ever come in contact with HPV.
Right.
So we want to give them time to build an immune response and not have to worry about it in the future. And that's one that we know confers lifetime immunity. So we don't have to worry about giving it at 9 years and then when they're presented with the pathogen or encounter HPV at 35.
Yeah. And why do we care about HPV? What's the big deal?
So HPV is remarkable from a vaccine standpoint. It's really kind of unique because we don't necessarily give the HPV vaccine to prevent, the classic viral illness or pneumonia or something like that. We give HPV vaccine to prevent cancer because it's a relative of the common wart. It's different strains of that actually causes cervical cancer, penile cancer, and if you get it before, then you've prevented cervical cancer. I mean, the rates of cervical cancer we're already seeing are just falling through the floor compared to what they were, 15 years ago before the HPV vaccine. It has just totally changed the face of that. And so to have a cancer vaccine is just remarkable.
Right. And, getting HPV has no bearing on, morality. It's
it's like the common wart.
It's so common, so it's hard not to come in contact with it, right? Yeah. Good. I guess one other category of vaccines that we could talk about would be with travel, so international travel. Sometimes I have a patient come in, they're for the physical, and they say, well, doc, I'm going to South America in 3 weeks. And I say, oh, gosh, we're a little late for this conversation. So what vaccines might we be talking about with travel to various parts of the world, and why is it important to make sure we have a special appointment to talk about this?
Yeah, I love travel medicine. I love hearing about all the wonderful places people get to go to. But it's important because we don't all have the same illnesses throughout the world. So in some of the more tropical areas, you see more mosquito-borne illnesses like dengue fever, chikungunya, yellow fever. And so having that visit with your physician and learning where you're going, it could give you a vaccine for some of these things. So again, if you come into contact, get bitten by a mosquito, your illness will be prevented.
Yeah, that could ruin your trip, right?
It could ruin your trip and then ruin some once you come back. Yes.
Right. Yep. What else do you talk about in a travel consult besides vaccines?
So we talk about other things of ways of preventing illness or preventing injury. So depending on where you're going in the world, I might prescribe malaria pills to prevent malarial illness because, again, that will ruin your trip and ruin probably maybe for several months afterwards. Talk about the importance of sunscreen and bug spray. Another one that's common is the typhoid vaccine. And so with that, talking about, look where you're eating and drinking food from and drinking bottled water if you're going to some place where typhoid fever is a problem. So
Yeah.
Lots of different things to talk about in a travel visit.
Yeah, good. And also a good opportunity, to make sure that, did you get your flu shot this year? Did you get your COVID vaccine? Because you're going to be on an airplane and going to be exposed to all that stuff as well. Yep. Great. We are down to the last couple minutes of the show. I guess I would just ask, when we're talking about vaccines, sometimes it's a hard topic to talk about if we're dealing with some skepticism, information. What big takeaway would you want our viewers to have, Dave?
Yeah, it's just, I can't stress enough of, earlier in my career, some of these cases of patients that I saw that had vaccine preventable illnesses that we just don't see as much anymore. And so it's one of the biggest success stories of modern life is that we just don't have these devastating illnesses like we have. But we have to stay vigilant, and we have to do our part to get vaccinated and prevent the spread and stay on top of these, because when you've seen one of these cases, they're just devastating, and you don't forget it.
Right. Anything to add in our last minute, Ashley?
I would say if you have questions, come and talk to us.
Yeah.
Talk to me, we'll have the conversation, and I'll try to help you work through some of these misconceptions or your fears, things that you are concerned about, and see if we can find ways to get that vaccine.
Yeah, right. I mean, I think, agreed, the change from now compared to 100 years ago and lifespan and childhood mortality, a huge part of that is vaccines. And so we're very lucky to live in a time where we have all of this available to us. And I couldn't agree more. We are here for you as a trusted source to try and help work through any concerns that you have. And that's why we trained all this time is to help you with these questions, right?
Yep.
Great, thank you. We will be back after this.
My name is Dr. Tad Jacobs, and I serve on the Healing Words Foundation, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
For 24 seasons, On Call with the Prairie Doc has been a premier source of health education. Join us as we uphold our commitment to deliver science-based health education rooted in trust. Don't miss out. Follow us on Facebook, Instagram, YouTube, and TikTok to explore the complete Prairie Doc library.
As we finish up this evening's discussion, I want to thank Dr. Sands and Dr. Basel for sharing their expertise with our viewers. And thank you to all of our viewers for tuning in tonight. We appreciate your continued support of our mission and for joining us each week for science-based health education. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question or it didn't align with our topic, send your questions to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on SDPB Radio. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio wherever podcasts can be found. Thank you for joining us for another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm, would say, stay healthy out there, people.
The gut is often referred to as the body's second brain, influencing everything from digestion and immunity to mood and energy levels. Gut Check, understanding your gastrointestinal health. Next time on Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions: Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,